Thank you. Thank you, Ms. Annette. It gives me immense pleasure in inviting Ecler Jaqua of Loma University Health, USA, to deliver her talk on the title, Obesity Myths and Facts.
Good morning, everyone. At least it's morning for me. So let me just share my screen. Okay. Perfect. Okay. So my name is Ecler Jaqua. I'm family medicine and geriatric doctor at Loma University Health. And today I'm going to talk about obesity myths and facts. I don't have any disclosure for this presentation. And this is my objective. So recognize and clarify some misconceptions about obesity, explain the definition, diagnosis of obesity, comprehend the genetic factors of obesity, know the anthropometric components and the clinical components of obesity. Obesity is a the most common chronic disease that we have, and of course, affect not just the heart, but everything else. And we're just going to discuss a little bit about some things that are true and some things that are not. So the first one, the first question is like, is obesity a choice and not a disease? So is that a myth or is that a fact? Well, so this is a myth, right? So it's not a choice, unfortunately, it's a chronic disease. So obesity is a chronic, relapsing, multifactorial neurobehavioral disease, which there is an increasing body fat that promotes adipose tissue dysfunction and result, of course, in all the health consequences. So we have metabolic consequences, which includes high blood pressure, diabetes type 2, high cholesterol, the biomechanic consequences, which is like obstructive sleep apnea, osteoarthritis, back pain, cancer, DVT, carpal tunnel syndrome. So that all that pressure of the weight and inflammation, and also psychosocial health consequences like depression, anxiety, panic attack, bullying, because of the way that the person perceives themselves. So here, let's talk a little bit about the BMI. So we diagnose the obesity according to your BMI. So normal weight, 18.5 to 24.9, and then starting at everything, like when it's 25 and above, that's where you start like being like overweight, right? And the obesity starts 30 to 34.9 is obesity class 1, class 2, 35 to 39.9, and class 3 or severe obesity is 40 or more on your BMI. And the childhood obesity is a little different because you go to the growth chart and it's percentile. So the overweight percentile is 85, 85 percentile to 95, and 95 and above is obesity, 99 and above severe obesity. So the BMI levels actually, they are different depending on the region, right? So for countries like China, Japan, India, so for a person, the overweight range is just a little lower. So the obesity at the West region is 30 and above. And China, for example, is 27, 29, Japan is 29, India 27. So why is a little lower? Because you ended up seeing the chronic disease or the effect of the obesity on a lower BMI. So I have patients here for different ethnicities and cultures, patients from Asia. And I even look at them, I was like, well, they look fit. We do the calculation, like if you compare lower numbers, but they already are having the consequences like the high blood pressure, the diabetes. And for the South and Central America is very similar to the South Asia for the numbers for the BMI. Another way actually to predict for metabolic syndrome, right? Because that's what we are looking for, is the waist circumference. So actually, if your BMI is below 35, is a better predictor than the BMI for a predictor for metabolic syndrome. Once your BMI is 35 and above, it doesn't work as well. So then we just rely on the BMI. So for men, we have a little bit of difference in numbers. So 40 inches or more, or 102 centimeters. And again, different cultures, ethnicities, lower numbers than the West region for you to start having and seeing the consequences and seeing the metabolic syndrome. Same thing for women. So women, we have waist circumference like above and equal 35 or 88 centimeters. And for the South Asian, Chinese, Japanese, lower, always lower than the West region. And there is a few different ways for how you measure a waist circumference. So if you go by the NIH, the waist circumference is like on top of your iliac crest. And if you go by the WHO way to measure is between the top of the iliac crest and your last floating rib. So it's a little higher. Great. Now let's go to the next topic. Obesity can be attributed to genetics. Is that a fact or a myth? Well, you guys saw it is a fact. My computer is just not acting right. So it is a fact. Actually, obesity can be contributed to genetics. So in 2007, a genome-wide association study identify actually a fat mass and obesity association gene, which we call FTO, that is like kind of like established locus, so localized on the chromosome 16q 12.2, that it can be associated with obesity. So certain alleles of the FTO gene may be associated with adiposity. So that's what they found, that if you have that FTO, your risk of having obesity is higher because it plays a role in controlling the feeding behavior and energy expenditure. So for example, so for example, if an individual carries one copy of the FTO allele, they can weigh 1.2 kilos more than an individual that doesn't have that FTO. And if you carry two copies, you can weigh 3 kilos more than a person that doesn't have any of the copies. So I know 1.2 kilos, 3.3 kilos is like, but it's not as much. I was like, yeah, but can make the difference. So a lot of the times, if the person has that FTO and maybe other things also that can contribute to obesity, it's just something that is just an extra thing that can make everything worse. Again, being overweight is never healthy. Well, so being overweight is never healthy. That's actually correct. That is a fact. So for the BMI 25 and above, for each 5 kilos, for each 5 point, let's say like 5 kilos increase on the BMI is associated with 30% higher mortality. It is also associated, like we talk about many diseases like cancer, diabetes type 2, hypertension, thrombosis, and to every 1 kilo in weight gain, the risk of you developing diabetes type 2 may increase by 9%. So what I want to show here is that, yes, being overweight, so a lot of people saying, hey, I'm overweight, even my patients here, but I don't have any medical problems. I'm doing fine. So why losing the weight? Well, because of all these things, right? That like, even though maybe you're not having anything at this time, the chances of having all these comorbidities is very high. Is higher than if you're not overweight. So the fat mass disease, we call this fat mass disease, is basically increasing body fat, like the name just describes, but it results in abnormal and pathological physical forces. And then you ended up developing like CHF, asthma, gastric reflux, hernias, myalgias, OSA, like I said, because of that physical force. Now, sick fat or adiposopathy is basically an unbalanced adipocyte and immune response that occurs to basically like some kind of inflammation and adipocyte hypertrophy when especially the abdominal obesity is present. And this abdominal obesity, all these immune responses, this inflammation can cause a cancer, high blood pressure, metabolic syndrome, hepatosteatosis, gout, and diabetes type 2. So if you are overweight from the BMI 25 to 29.9 at age 40, you're basically going to live around 3 years less than a normal BMI. If your BMI is 30 to 35, which is kind of like a class 1 obesity, the median survival rate is reduced by 2 to 4 years. And if you have a BMI at 40 to 45, which is class 3 or severe obesity, it can be reduced by 8 to 10 years your median survival, which is basically the effect that is comparable with the effect of smoking. So that's pretty bad. And if you have both, you have the obesity and the smoking, then you can live less, like 13 to 14 years less than a person with normal weight and doesn't smoke. So individuals reported to be metabolic healthy, right? But obese, like I said, or overweight, they have this higher chance of having all these comorbidities. So even though maybe you don't have it at this time, you have a higher chance. Or some people, they have it and they don't know. Okay, obesity is not associated with sleep. Is this a fact or this a myth? So let's see. So actually, this is a myth. It is associated with sleep. My computer is working. So obesity is associated with sleep. So how come? So is sleep, I love this citation, is the most sedentary activity yet. Maybe the only sedentary activity that protects from weight gain. That's the only one that you can do it, no issues. It's going to protect for you to gain some weight. So I always tell my patients, like, I don't have time to sleep, I need to work. It's like, please sleep. That's the only sedentary activity that you can do that is going to be protected for weight gain. WHO and CDC, they recommend 7 to 8 hours of sleep at night. And adults sleeping like 5 hours and less, they have 55% more likely to have obesity if you compare with the people, like with the individuals that they sleep 5 hours or more. And every additional hour of sleep, it is basically like, if you have like for each hour of sleep that is decreased, the incidence of obesity increases by 30%. And if you sleep like less than 6 hours, the probability of obesity is like by 6%. So there is all these numbers just to show you that if you sleep less, there is a probability of you to have obesity. So having the genetic factors, the sleep issues, everything on top of that, everything like together, it can increase a lot the risk of having obesity. And look how interesting is sleeping from 8.5 hours to 5.5 will burn 400 less calories. So maybe that's a good way to talk with your patients, like, and talk on the language, like, hey, if you sleep your 7 to 8 hours, you're gonna burn more calories, or like you're gonna burn less if you sleep less than that. So this is just like benefits of having like 6 to 8 hours of sleep per night, ideal 7 to 8. But you know, all of us, we have better mood, better ability to focus. We probably like, not gonna be as sleepy during the day, more willingness to exercise, decrease the caffeine intake, which is good, good for your health. Less cravings for sweet and salty foods in the evening, which can be another thing that can also make you gain weight, and lower risk major cardiovascular events and deaths. So a reduction of 1 hour sleep is associated with a 0.35 increase in BMI. Children also who sleep less than 10 hours per night can have an 89% greater risk if comparing with their peers who have obesity. So very high number here. Morning individuals, usually like the morning, the people who like to wake up early, they have lower BMI than the night owls. And the late sleepers, and that's so true, like they ended up consuming more calories because you ended up having, if you are awake at night, you're like, we're hungry, or ended up going to food with like, they have more sugars and more carbs. So you ended up consuming more calories at night if you sleep late. This is a very a graph that I like to use because it just show like kind of like the cycle, right? The no-ending cycle. So you have insufficient sleep, and then you basically your homeostatic feeding behavior, right? So if you don't sleep as much, you ended up eating more. You have more hunger, right? You're more hungry and hangry. And then you have the non-homeostatic feeding behavior, which is the exposure, right? Exposure to is the rewarding. So it's not just it's just not hungry, but you also is the reward. You're looking for foods that give you more reward, which is usually the carbs and the sugary food. Your energy intake is increased, right? And then you have the fat gain. Also, when you are insufficient sleep, you don't have that energy, right? So you ended up not doing your physical activity because you're just tired and fatigued, and then your energy expenditure decreases. So this is not a good combination. And then also you have with that the fat gain. So ideally is you need to decrease the energy intake and increase the energy expenditure. I know it's easy to say, but I just want you, and difficult to do, but it's just like looking the cycle, right? All the end of all the things here ended up with the fat gain. And this is our last topic. So there's no relationship between breastfeeding as an infant and obesity. Oh, this is a myth or a fact? Actually, this is a myth. So breastfeeding is very important because it can reduce the risk of obesity. So the rates of obesity are significantly lower in breastfed infants. There is a reduction of about 15 to 30% in adolescent and adult obesity rates if the breastfeeding occurred during infancy when you compare to kids that they didn't breastfeed. Each month of breastfeeding is associated with a 4% reduction of risk of obesity. And why is that? Because the breastfed infants, they are more likely to self-regulate the intake volume, which affects the weight gain. So it's not just the maternal milk, is the fact of being like the breastfeeding that is important because it's a self-regulation, right? So if you give the breast milk on the bottle, breast milk is always good to combat so many diseases, but they're not going to have the same effect for the self-regulation that if they have on the breast. So that's a very important point for that. And yes, like, so when they drink in bottles, they just don't self-regulate. So it doesn't matter if it's formula, if it's the breast milk, here what we are talking about, like even though we always make sure and incentive our mothers to give the breast milk as much as we can, but the breastfeeding is very important for self-regulation. So the American Academy of Pediatrics recommendation, so basically exclusive breastfeeding for about 6 months. And then after 6 months is recommended to continue as complementary, like, you can continue, and then complementary foods are going to be introduced, your solids, and the continuation of the breastfeeding for 1 year or longer, it just depends on the mother and the infant, right? So I have many patients here that they are breastfeeding for like even more than 2 years. So it's whatever is desired by the mother and the infant and the baby. But that 6 months exclusive breastfeeding, that's very, very important for self-regulation and decrease the risk of obesity in the future. So these are my references, and thank you so much for the invitation, and I'm open for any questions.
Well, I must say, I didn't want to say a lot on obesity, but this was what we teach people, especially the sleeping thing. I don't know about you, but we don't sleep well. We're forever stressed. We're forever not sleeping well. We're overwhelmed. And especially in healthcare, I must say that if you work like shifts working, like night and day, you don't sleep well, and look at the staff. You forever nibbling, you don't exercise, you are eating whatever you can grab because there's no time to eat good food. And this is evident that if you don't sleep well, you will gain weight. And this about the exclusive breastfeeding is also true. We teach the parents to choose one. And in Saudi Arabia, I must say, we changed the culture of try to breastfeed. We do know all the excuses, all the problems people have regarding to breastfeeding, but just try. Just try, and you will see the babies are better. We see babies, small babies, that they obese, and I see more obese children, diabetic children, and unhealthy children because they don't use their energy correctly because they're forever in the house, and also it's too hot to go outside for them, and we see the effects of that.
Yeah, that's correct. And we are seeing so many each year, like more kids with obesity, overweight, and the breastfeeding just one component, of course, you know, it's just an education, the whole family about the food that they are giving to their kids. But yeah, that's something that is interesting. Breastfeeding is not easy, like you said, you know, it's not. But in the end, you know, if we are able to teach our mothers and educate them, you know, like it's just something that is going to be good for their kids, right?
Yes, that's true.
See one more hand from Selva. Can you ask your question?
Sorry. Yes, I have a question. Can I do?
Yeah, sure.
Okay, thank you so much. Nice to meet you. Dear Ecler, congratulations for your presentation. I just have one question. You are talking, can you listen?
Yes.
Thank you. You are talking about the different classification about BMI. It's okay. Do you have this article about this subject? If it's positive, can you share with us?
Which article? I'm sorry, sir.
About the BMC in different classification.
In
It's about the
different,
culture.
Culture. Yeah.
Yeah.
Actually,
Yeah.
you know what? I'm also obesity medicine certified. So all that information was on my board review for my test, but I want to try to find at least those chapters and send it to you.
Yeah.
That probably have the references. But yes, that's very interesting. And then they even have like a table with the ethnicities and how different it is, because it is true. If you are from this culture and ethnicities, you see the disease is coming with a lower BMI. So they don't need to have that higher BMI to start having the diseases. Lots of I have some patients, like I said, from like Asia that I come and see me, and I'm telling you, I look at them, I was like, oh, they are great. Probably BMI is normal, which it is, right? It's normal for us, but already having the diabetes, the high blood pressure, all the comorbidities. And I was like, okay, now I understand why they ended up having to lower the numbers for us to be more careful with this population, even on a lower BMI. But I'll try to find, and I can send to the email from the conference, and then they can send it to you.
Yeah, it's interesting because I'm living in South of America, Brazil. Then we have a different
I'm
culture.
sorry, are you Brazilian?
Yeah.
Eu também.
Yeah.
Me too.
Prazer conhecer. Sorry.
Prazer.
Then in this country, how do you know? We have a different population. It's very important when we see the different classification about the BMI. Thank you so much, Ecler.
Of course. Yes, I can send it to the conference email, and they can send it to you. But yes, I'm Brazilian too.
Yeah.
In Brazil is the same as here in the United States. But yes, I saw your name, Sylvia. I thought it could be Brazilian, but yes, nice to meet you.
Yeah. Thank you. Nice to meet you. Thank you.
Any further question from the floor? I guess there is no question.